Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I welcome Professor Bill Walter on, who is a specialist hip and knee surgeon with over 20 years of experience. Bill has performed thousands of joint replacements, and total hip replacements will be the focus of today's discussion. For hip replacement, Bill uses high-quality implants via either the anterior or posterior approach, and he is one of the few surgeons offering hip resurfacing, which is ideal for men under 65 typically. A warm welcome to Bill.
Thank you very much. It's good to be here.
Yeah, I've been looking forward to this for a while, and I actually haven't had someone on that is a surgeon that specialises in joint replacements yet.
Okay.
So this is an exciting topic, and a lot of the listeners have asked me about this over the years. Now, in true podcast style of the Wild Physio podcast, we're going to go with some yes, no, and maybes to start with.
Mm-hmm.
Then we can delve into why you answered, how you answered. Let's see how you go. First question. Does the amount of osteoarthritic change seen on imaging determine when one will need a hip replacement?
No.
Do some surgeons and physios advise their patients to wait too long to get a total hip replacement?
Yes.
Do you prefer to use the terminology of age-related change to describe osteoarthritic change?
No, I don't use that term. No.
Can one run after a total hip replacement?
Some people can.
Can one run after a hip resurfacing?
Yes, usually.
Can they play tennis after a total hip replacement?
Yes.
And a hip resurfacing would be the same?
Yes.
Yeah. Is there a gold standard total hip replacement prosthesis material?
Well, yes, there are different parts and they have different materials. There's titanium for the bone fixation, and then a ceramic head or ceramicized metal, and then a polyethylene liner.
Got it. Should we always adhere to post-op total hip replacement hip precautions?
Not always.
If someone is overweight or obese before they get a total hip replacement, will you advise them to lose weight?
If they can, but it's not absolutely necessary.
In your opinion, is there a gold standard or Rolls-Royce total hip replacement approach?
No, there are several good approaches to the hip.
Does hip resurfacing have a lower dislocation risk or rate than total hip replacement?
Yes.
And will up to 90% of total hip replacements still be intact and functioning after 20 years?
Yes.
Well answered. We're done.
Okay.
That's it. All right, so we can delve into why you answered like you did
Mm-hmm.
now. But before we do, what I want to do is just ask about your career and also the big reason why you got into medicine.
Okay, well, I've always been interested. Well, my father was a surgeon. He's retired now. But he was a very well-known and very highly respected hip and knee surgeon. So my mum tells me that at the age of 5, I said I wanted to be an orthopaedic surgeon so that I could help Dad. So I guess I knew about it from very early on. And I've always been interested in engineering and in working with my hands. And so I was interested in trades, I was interested in engineering. But orthopaedics is really like the tradesman of medicine. So for me, it's been the perfect career. There was a time when I was really choosing between engineering and orthopaedic surgery. It's always been orthopaedic surgery, between engineering and orthopaedic surgery, but I picked orthopaedic surgery.
And why total hip replacements, total knee replacements? Obviously you do other surgeries, but they've been obviously a focus for you over the years.
Yeah, well, total hip replacement's a really interesting mechanical and engineering challenge. Merv Cross used to say that every knee replacement should be a masterpiece. And that's the way I view it. Every surgery you do should be a masterpiece. There's so many nuances to getting it right, from the positioning of the implants to the soft tissue balance, the way you treat the tissues, the patient selection, and then of course the devices that you choose. So it's a great operation and the results are fantastic.
And for the listeners out there, we get a bit of a mix of listeners. We get physios, medical students, we get just general public listening in. So even for the general public now, could you describe to us about how a total hip replacement goes ahead and the different approaches that you would typically see?
You mean the surgery?
Yes.
Yeah, so the surgery's done in an operating theatre under anaesthetic. So the patient's either got a spinal on board, so they might be awake talking, or they might be asleep altogether. Patients either on their back or on their side on the operating table. We prep and drape. So we prepare the skin with betadine and then drape it. So we have a sterile field, and we put an IOBAN or a sticky coating on, and we make an incision through the skin, through the fat, through the deep fascia, and then we do our surgical exposure, the commonest ones are anterior approach or posterior approach, which is really a posterolateral approach. And so we're always trying to minimise the amount of damage we do to the tissues. But you'd split the muscles, cut the capsule, and then usually dislocate the hip. And then we take a saw and we remove bone. With the resurfacing, we're removing a small amount of bone. With hip replacement, we remove the whole femoral head and the femoral neck. And then we remove some bone from the acetabular side as well, and then put the acetabular component in the socket, and then put the femoral component on the femur, either a resurfacing or a total hip. And then there's trialing to make sure it's balanced and stable.
When you say trialing, what do you mean?
So we'll reduce the hip. I should say we also use technologies for alignment. So precision is very important. So we have techniques with sensors and different technologies that we use to balance the joint and get the alignment right. So that is the alignment of the parts attached to the bone. And then we trial. So that means with either the trial components or the definitive components, you reduce the hip and you put it through a range of motion. So we actually move it on the operating table to see if it moves the way that we think it does. And these days we've got very advanced planning technologies as well. So we go in with a very good idea of what sizes we need and what orientation we need. We use sophisticated three-dimensional planning that involves artificial intelligence to get us landmarks. So before we close, we do a trial to make sure everything looks and feels the way it should. And then we carefully close the tissues, finally close the skin, put a dressing on, and then wake the patient up. We usually get them on their feet within a few hours.
And when it comes to the different approaches, the anterior versus the posterolateral approach, what muscles are you typically splitting with those? And why would you choose the anterior over the posterolateral approach? What determines that?
So I'll start with the posterior approach. For a start, it's the commonest surgical approach for hip replacement in the world, including in Australia, where about 70% of hip replacements are done through a posterior approach, I believe, at the moment. It's a very versatile, safe approach that allows really good exposure to the hip. If you think about the way the hip moves, it flexes, so it moves forward. So if you make an incision at the back and you flex the hip, you can look down the femoral canal and you can look up into the socket. Whereas the hip doesn't extend to the same degree that it flexes. You can extend the hip a bit. So if you make your incision at the front, you can only extend it a little way, so it's harder to look down the femur and up into the socket. So posterior approach has that advantage that it's with hip flexion, you get very good access to both sides of the joint. So the incision is usually just behind the greater trochanter. We split the deep fascia, which is the fascia lata, which has the tensor fascia lata attached and the gluteus maximus attached, but we usually split gluteus maximus, so longitudinally. So the fibres are, in an orientation, and the incision's in the same orientation, so the fibres just split, and at the end of the operation they just fall together and they are retracted. But then we do divide some muscles in a posterior approach, which are the deep muscles to the hip, particularly the deep short external rotator muscles, so piriformis and the muscles that go into the conjoint tendon and quadratus femoris, which I can list for you if you want. But
No, we don't have to go into that, but yeah, keep going.
we also sometimes divide a little bit of gluteus medius tendon into the back of the femur. But all of those muscles are repaired, and the gluteus maximus just falls back together. But with an anterior approach, we're coming in from the front, and we're actually in an internervous plane from the front. So that means that we are between two muscles that are supplied by different nerves, which is the ideal approach in surgery. You want to be between two nerves, because then you're not denervating anything. So we come in front of tensor fascia lata, and on the other side of that exposure is sartorius and rectus femoris and some other muscles, and they're supplied by different nerves. So you come down actually on tensor fascia lata, we retract that laterally, and that sometimes gets a little bit bruised actually and can get damaged with an anterior approach because of the retractors. You have to force it back because you can't extend the hip in the same way. So there sometimes is a little bit of damage to that muscle. And then when we're down on the bone, the femur, we cut the neck, and we're actually dividing a little bit of the insertion of piriformis with an anterior approach. You have to release a little bit of its insertion. So it's not true that there's no muscles divided at all through an anterior approach. There is a little bit of tendon release.
Do you have a preference on the surgical technique?
Yeah, so I started my career for the first 10 or 15 years doing a posterior approach, and then I switched to an anterior approach in about 2012. And I've been looking at it carefully for 8 or 10 years before that, because I was concerned about the learning curve with the transition, but I did it very carefully. And I moved because it allows actually greater precision, anterior approach. So people talk a lot about the muscle preservation, but I like the fact that the patient's supine on the operating table. So I've got access to their pelvis. I can palpate the bony landmarks, the anterior superior spines. I've got their legs lying straight out, so I can measure the leg length directly. It's very easy to use computer navigation, and it's very accurate to use sensor systems to get the accurate placement of the components. So it's more precise in my hands. It's also a little bit safer because the patient's supine, so the anaesthetist has great access to them for airway management and vascular access if they need it. And it's a little bit easier on the patient in terms of their shoulders and arms and things. So, and it's quick and it's just simple.
Why isn't it done more frequently?
Well, posterior approach is a very good approach, and it's really familiarity of the surgeon. I mean, I did thousands of cases through posterior approach as well, so I'm comfortable with that. But it's, I think it's what you learned mostly. And most surgeons who do both would do, I think, predominantly anterior approach for simple cases. And I still use posterior approach for difficult cases. So if you've got abnormal anatomy.
Such as?
So, well, I've just been seeing some patients today, and we were planning the surgery for them, and they've got dysplasia, which means that they've got an abnormal shaped skeleton. So this patient we saw today had a congenital dislocation of the hip, or developmental dysplasia of the hip. So the socket's very shallow. There's a lot of femoral deformity as well, a lot of femoral anteversion.
How old are we talking?
This patient was about young, 32. Yeah. And previous surgery as a teenager with scarring. So that makes it more difficult. So all those things, you've just got more options through a posterior approach. If you need to extend the exposure down the femur, you can get great access to the middle and distal femur if you need to. If anything happens, sometimes you can get fractures, or you might need to do an osteotomy down there to change the rotation or shorten it. So you've got a bit more versatility through a posterior approach.
And in terms of how long it takes for both approaches, how long roughly on average would it take for either?
It's a little, in my hands, it's a little bit Well, the setup time's quicker for an anterior approach, so it's quicker to get them on and off, and the anaesthetic time's quicker. And then the surgery time is also a little bit quicker in my hands, not by much, a few minutes, and then the closure's quicker with an anterior approach because you really don't have much to close. It's just a bit of fascia and then skin, fat and skin, whereas with the posterior approach you're repairing those muscles.
So total time for an anterior approach, how long would that typically take?
Well, the actual surgery is only about an hour.
Okay.
By the time they get on and off the operating table, it's about 90 minutes.
And how long would have a hip taken back in early 90s compared to now?
Oh, they probably took a bit longer.
Yeah.
We're getting quicker and more efficient. Maybe an extra 30 to 60 minutes.
Is that mainly based off the fact that everyone's getting better at it because they're doing a lot of them, but also the fact that technology's come into play with it?
Yeah, so technologies, well, I mean, the implants are good, so the fixation's great and the implants are designed to be put in easily and the instruments are better. But if you're talking about assistive technologies, robotics, sensors, navigation, they can actually slow you down or they can speed you up, depending on how complicated they are.
Yeah.
Some of them are more complicated than they need to be and can make things slower.
What do you think the future is with AI, where we're going with robotics and where we're going with surgical intervention going forward?
Yeah, it's a good question. I've been thinking about this for a long time and we're really, in this takeoff point now. Some people are calling it the singularity, where things are just accelerating at an unbelievable pace, particularly around artificial intelligence. The robotics, I think, is still really coming. We do have some robotic assistance and some sensor technologies, but I think that'll continue to change. But I've been saying for a long time that as a surgeon, we're really doing we have sort of three roles that are separate challenges for technology. One is we see the patient and we take a history and we examine them and we look at the imaging, the x-rays, and we make a diagnosis and then we decide what needs to be done. So that whole algorithm about deciding what surgery to do is really an information technology problem. And we're seeing artificial intelligence and information technologies coming into that. Like I said, with the surgical planning, x-ray analysis, we're using AI tools for that. We're using artificial intelligence tools, to help us analyse other patient information as well. So that's already sort of there from an assistive point of view. The next part of the surgeon's role is the surgery, where you are. But that's not just the actual cutting the bone. I mean, the technologies we have at the moment are just about cutting the bone, but you've really got to get them on and off the operating table. You've got to position them correctly. You've got to know where to make the incision. You've got to do the soft tissue dissection. You've got to be able to control bleeding. You've got to be able to control problems as they arise. And really, none of the technologies we have do any of that. All they're doing at the moment is helping you cut the bone.
So you're not worried about your job going forward?
Well, I haven't told you what the third thing is yet.
Right.
I think the first thing, the information technology problems, are probably the first thing to go. And I think robotics, like I said, it's currently just a precision device that helps you to do the surgery more accurately, to cut the bone or to place the implants. It doesn't do those other things. But that'll probably come. There'll be some of that in the next 5 years. But the third thing, which is not the last thing we do, but it's what we do at the beginning and all through, is we look a patient in the eye and say, don't worry, I'm going to look after you. I'll be there to look after you, whatever happens. And I think patients will always want that.
Well, they need that.
Yeah.
You can't get that via a robot or something. You need that human connection, don't you?
Yeah. And you need the human connection, exactly. And, because these are not just hips. These are people with lives. They've got kids and they've got wives and they've got dogs they want to take walking and they've got careers they want to get back to and they've got all of these other things that are part of the picture. And if you don't understand that. You need to connect with that side of it as well, because ultimately the reason we do the surgery is not to make the x-ray look better or to improve, some sort of mechanical aspect of the hip. The reason we do the surgery is to improve the patient's quality of life.
Exactly.
So you need to understand how the hip arthritis is affecting their quality of life and understand what the risks and benefits of the surgery are and what our chances are of improving their quality of life. So that's where the human connection comes in. But I think there's something even beyond the human connection, which is just knowing there's a human there. And a great example is with aviation and with automatic pilots. There's autopilots in all of the aeroplanes we fly in. It's been around for 50 years. So you could get a 747 or an A380 to take off in Sydney and fly and land in Los Angeles without anybody in the cockpit. But nobody wants to get on that plane.
Yeah, exactly. Well, people are getting in the Waymos now,
Yeah,
driverless cars.
So that might change.
Yeah.
That might change. They might get in aeroplanes without a pilot.
I think at some point that'll probably happen.
Yeah.
In our lifetime, maybe. We'll see. It's moving at a rate of knots and it's kind of scary, but you touched on the osteoarthritic change just then when you were just discussing that. I did ask you at the start, does the amount of osteoarthritic change seen on imaging determine when one would need a hip replacement? And you said no. Why? So a lot of people come and see us as physios or doctors and they've had an X-ray or an MRI and it says they've got osteoarthritic change, and they may have a considerable amount of osteoarthritic change and they may or may not have pain. Why? And when do you typically pull the trigger on a total hip replacement?
So they have to have hip pathology. They have to have arthritis. But the severity doesn't correlate, like the radiographic, or how it appears on X-ray, radiographic severity, doesn't correlate with the timing of surgery. Because the timing of surgery is based on the quality of life. And so for some people, the reason they have a hip replacement is because they want to go rock climbing again and they want to go bow hunting, or because they want to go surfing and they work as a plumber. For some reason, the reason to do hip replacement is because they can't get out of their bed to go to the bathroom because they're 80 years old and they're losing their mobility around the house. So there can be quite different reasons for doing the hip replacement, and the severity, you can have severe arthritis, but if you don't need to do anything and it's not your limiting factor, then you wouldn't replace the hip. You can have less severe arthritis, but it's the thing that's holding you back, so in that case you'd do it.
And when I asked you about if some surgeons and physios advise their patients to wait too long, and it's a last resort option, why do you think that is the case, that some people do say just wait and wait and wait and wait, and they get to the point where they're in so much debilitating pain and also their functions dropped off a cliff? Do you think things need to shift a little bit with people's thinking around this?
I mean, well, it's right to be conservative about recommending surgery, because the last thing we want is people doing surgery too early before patients really need it. But I think there's a bit of a lag in the understanding in the community, including in some physiotherapists and some doctors, about how good these things are. There's a very common belief that hip replacement will last 15 years, which is completely incorrect.
Well, you said in those yes, no, maybe questions that 90% of total hip replacements are still intact and functioning after 20 years.
Yeah, in fact, 90% of them are still intact after 30 years.
There you go.
And we don't know what happens at 40 years, but it's probably still going to be 90% at 40 years. Because what happened was, in the 1990s, we had these materials with polyethylene that was being gamma irradiated in air. So the manufacturing process of the polyethylene meant that it did wear out in 15 years. And what that means, if you do 100 hip replacements, 50 of them have had another operation by 15 years, half of them. And now we're seeing much better materials. So we've had much better materials for more than 25 years. So the the materials started to come in late in just before 2000, around 2000, really all the materials were very good. And so all the hips done after 2000, not all of them, but the vast majority of different designs and different materials have lasted incredibly well. And we're just seeing, so there's risks that occur early in the first 2 years. If it's, you can have dislocation or infection, they can loosen. That is more common in the first 2 years, but if you make it through the first 2 years, and there's only about a 1 or 2% risk you'll have a problem in the first 2 years, but if you make it through there, the risk actually drops per year. And so we're seeing, a linear rate of failure at less than 5% per decade, 3 or 4% per decade.
For the listeners out there, Bill's actually been kind enough to bring in some of the prostheses today, and let's just go through some of the materials that they are using for not only the hip replacement but also the resurfacing. So what are they typically using? You touched on it in the yes, no, or maybe questions, and you can use the props if you like to discuss them.
Yeah, okay. So we've got, this is a femoral component, so a femoral stem that goes inside the femur. And these are typically made of titanium, and they've got a growth surface on them, which is usually plasma spray titanium with hydroxyapatite, which is bone mineral. But titanium is a very good material for implant fixation because bone grows really well onto titanium, and it's less stiff than some of the other metals. So stainless steel and cobalt chrome, which we used to use, twice as stiff as this. So it's less stiff. And then the ball, in this case, is an alumina ceramic. So we now use alumina ceramics that are usually a different colour because they're usually pink, but it's either ceramic or ceramicized metal. And on the socket side, we haven't got a cup here, but they're titanium shell, usually with a polyethylene liner, so a highly cross-linked polyethylene, which is a great plastic material, and sometimes a ceramic liner instead. So they work very well. And the wear of those, so the wear of the modern polyethylene ceramic combination is probably 10 to 100 times less than those hips I was talking about from the 1990s.
Wow.
So if they wore out in 15 years, I tell people that'll probably, your hip's going to last more than 150 years based on the material properties and the laboratory studies of wear. Now, that effectively means we've eliminated wear as a failure mode. So,
phenomenal.
Yeah.
It's a big change. Some of the patients over the years that have seen me before, they've had a total hip replacement, been concerned about the materials leaking or leaching into the body. Can you just break down what happens and if that actually does happen at all?
Yeah, so in the total hip with a polyethylene liner, you will get polyethylene wear debris. So all moving parts wear.
There's a breaking point for every material.
Yeah. Yeah, and anything that moves against something else will produce wear. So the wear. So let's start with the 1990s hip that had polyethylene that wore out in 15 years. Let's say the modern poly is 10 times better than that. And you still get polyethylene wear debris. That just moves around locally in the joint, and it can get absorbed by cells, and it can cause bone loss and inflammation of the capsule. But it's still 10 times less than we saw it in the 90s. The other material that we use for resurfacing is a cobalt chrome on cobalt chrome. And so this has got another order of magnitude less wear, so 10 times less again. So it's 100 times less than the 1990s hip. But the wear debris from this is a different material, different to polyethylene, and cobalt chrome particles are actually more toxic than polyethylene. Polyethylene causes chronic inflammation. This material causes cell death and can cause nasty local reactions. It's quite rare, but it can happen. It also is absorbed into the blood and excreted in the urine, cobalt chrome. And we've studied that very carefully for many years. And as far as we know, there's no adverse effects from that cobalt chrome in the blood. But the cobalt chrome wear debris, like the polyethylene wear debris, can cause local problems in the joint that can lead to failure, which is why we've moved to the ceramic with the resurfacing. So these are both resurfacing components. The difference with a resurfacing to a total hip is mainly on the femur. So with a total hip, it goes inside the bone, resurfacing goes on top of the bone. And so the modern ceramic on ceramic bearings in resurfacing have very good wear. So the wear compared to our 1990s hip, this is 1,000 times less.
Wow. And it's unbelievably smooth as well when it's in. Like, it's just moving just fluidly through that, isn't it? And obviously that's what it's designed to do. It's pretty incredible when you actually have it in your hand and you're starting to play with it.
It's very precise engineering, so it's 5 microns of tolerance on the roundness and 30 microns of clearance, and it just moves absolutely beautifully. So that's a ceramic on ceramic bearing. So as well as being 1,000 times less wear volume than the 1990s hip, ceramic debris is also inert. So it doesn't cause chronic inflammation like polyethylene, and it doesn't cause cell death like the metal. So that's why it's such a great material, ceramic. And this one's got a coating with titanium for bone ingrowth, with hydroxyapatite on it. And on the femoral side, we use bone cement to attach that.
And that titanium side is actually quite rough, isn't it?
It's a rougher surface.
A rougher surface, yeah.
Yeah.
Yeah, it's incredible. So I touched on that in the intro, the fact that you do the hip resurfacing. Let's dive into that. What is a hip resurfacing, and typically what type of patient is it reserved for?
So hip resurfacing, I'll just grab another prop here. We've got a femur. So with a, can you pass me that? With a total hip replacement, we take a saw and we cut the head and the neck off. And so we remove all of this bone, so that the bone looks like this with the head cut off. And then the femoral component in a total hip replacement goes inside the bone, all the way down, so about to the midway down the thigh. Now they work very well, but the bone is not static when you're moving, particularly when you're sort of dynamic and doing a lot of impact. The bone actually bends, and if you've got a stiff piece of metal inside the bone, people are aware of that with running and jumping and more dynamic stuff. Plus we've lost the neck and the head, so the diameter of the head's smaller, the neck's gone, so the proprioception's not quite there. So with the total hip replacements, they're very good, but they're not quite as good as your native hip, and not quite as good as if you can preserve the neck and the head. So with resurfacing, we just remove a little bit of bone and we put the resurfacing component over the head, and so we're preserving the neck. So they get a more natural sort of loading of the femur and flexing of the femur. We restore the biomechanics a little bit better because we're not shifting the head center as much. We've got the proprioception from the neck. So all of those things add up to a slightly more naturally feeling hip if you do a resurfacing. And on the socket side, this has to go into the pelvis either way. You put a cup into the pelvis. But the big but with resurfacing is that we are relying on your femoral neck to hold this thing. And the femoral neck's, I think, the commonest bone in the body to break as you get older. People, as they get old, they fall over and they break their hip. That's usually a femoral neck fracture. So this is one of the most vulnerable parts of the skeleton for fracture. And if you've had someone with arthritis and they haven't been walking on it for very well, so they've got osteoporosis and then they've got some bone loss and some cysts, and then you take it off and you get instruments and you cut it, and then you put this on and you've got this stiff implant, they can have a femoral neck fracture if you don't have good bone quality. So we have to select our patients carefully, mainly around bone quality. And one surrogate for bone quality is age, because younger people on average have better bone than older people. As you get older, you get osteoporosis, your bone gets weaker, and particularly when you've got arthritis, if you're not loading it, your bone density goes down and it gets weaker and can break more easily.
That's where we come in.
Yeah, that's right.
Loading the bone, playing change of direction sports, jumping, these type of things, try to mitigate that loss.
Yeah, absolutely. Yeah, that's another, it sort of plays into that question of when you do it. You asked if people leave it too late. So you'd know very well from your work and your practice with patients that if patients get injured, they lose muscle and they can lose bone density. muscle mass and bone density, and we're learning that muscle and bone density. So it's called sarcopenia when you lose both. So sarcopenia is a bad predictor of longevity. You live longer if you've got better muscles and better bones.
Big thighs save lives. I always say that, Bill.
Do you?
Yeah. Patients like, I've got a cup at work actually, and it's got that quote on it, big thighs save lives, and I'm always drinking out of it, and patients always see it. It's so true.
Yeah, it is. So, you can leave a hip. So apart from, the decision about when to do a hip replacement, if we just digress to that for a minute, depends on, they've got to have enough symptoms, and they've got to have ambitions, or they've got to be missing out on things that we can give them back. So if somebody wants to run a marathon and they only get a hip pain after 20 kilometres, it wouldn't matter if they had arthritis, you wouldn't do a hip resurfacing for that. If they can walk and live and sleep and do everything, but they just can't do some really ambitious goal, that might be too much. But so the goal has to be achievable with surgery, reliably and realistically. But we also sometimes, want to encourage people to have surgery if they're really losing condition. So if they're going to lose their muscle, as you get older, as you lose muscle, you can't get it back. So you're better off getting them, and if they're on a decline with their arthritis, you can sort of wait. You can do it, if you do them too early before they even start to decline, that's not, that's taking too much risk. If they're starting to decline, that's when you want to do it. You don't want to wait until they hit rock bottom, because you can't get it all back.
It's finding that sweet spot. I think I've seen a couple of patients over the years that have come in and seen me after seeing another physio over the years, and that physio has said to them, you got to wait, and it got to the point where they saw me and they're limping horrendously, they've lost a hell of a lot of muscle mass, they've lost function, and they've just been in excruciating pain for a couple of years. And they're 60 or 65 and they're worried about the life of the hip.
It's going to last a lifetime.
Exactly. Yeah, they should have just gone and seen you, and that's exactly what we did with them. We said, all right, you need a surgical consult. You don't have to just suffer through this. There is an alternative.
Yeah, so that's very true, and that's one element of it, is that they are going to be a poorer candidate for surgery if they've been disabled for a long time. They'll have higher risks and they'll get a poorer outcome.
And they may have put weight on as well. That was another question I asked you about if they're overweight or obese, and if they haven't been exercising as much because their hips so bloody sore. Well, the chance of them putting weight on is quite high.
Cardiovascular fitness goes down, mental health, all of that. The other thing is they've just missed out on 5 years of their life. So they've had when people have arthritis, their world shrinks, so they can't, they might be a person that gets out, and for a lot of people in Australia and Sydney, physical activity is a big part of their social life, particularly for guys. We don't go and meet each other for coffee like some people do, but a lot of people meet people for exercise, and that's their social life, whether that be golf or a bunch ride on the weekend, tennis, or go for a swim or a tennis. It's a big part. So if you can't do that, you can't participate, you just end up sitting at home, and your world and your life shrinks, so it affects your social contacts as well.
Absolutely. And Andy Murray made this surgery popular because it was in the media so much, because he had the osteoarthritic change through that hip, and he eventually had the hip resurfacing, and he returned to professional tennis. And when I did ask you if one can return to tennis or running after a hip resurfacing, you said yes. You've touched on it, why that is the case, but did it surprise you that Andy Murray could return to the level of tennis that he did?
Well, he did very well, didn't he? Because he won a European championship, like a singles European men's championship after his hip resurfacing.
Have you watched the documentary?
Yeah.
Yeah, it's quite fascinating. I loved it.
And I know Sarah quite well,
right.
the surgeon.
Yeah.
Actually, she's coming out next week to Melbourne.
There you go.
But Sarah Muirhead Allwood. Yeah, so Andy's he did really well, but that's a typical result that we'll get. I mean, Andy's a very disciplined, motivated, athletic guy, and I joke with patients that if they say, "Can I play tennis?" and I'll say, "Well, you won't be able to play as good as Andy Murray."
Not many people can. No. Probably the top 10 players of all time, just about.
That's right. So we can certainly return you back to your level of activity. often, usually. Yeah, and so tennis, golf, all that sort of stuff.
I'm cognizant of the time. We've been going about 40 minutes. I know you have to head off soon. I think I could talk to you for hours about this. Is there anything else that you really wanted to touch on before we finish up the podcast today about total hip replacements or the hip resurfacing?
Yeah, well, there's an interesting finding which is in all of the registries about the difference between resurfacing and total hip. And there's a lot of debate as to what the reason is. But all of the data shows that people who have resurfacing live longer on average than patients that have total hip replacements. There's a lower mortality in patients that have resurfaced hips. And there's a lot of debate about whether that is because of a selection bias, because the patients seeking hip resurfacing are motivated and athletic and fit and look after their health in a different way. But even after you correct for age and other factors, there's still that difference in mortality. So there may be an effect of putting the femoral component down inside the stem that embolizes fat that has a slight increase in mortality. So that's another interesting thing that we're still trying to understand. And no, the hip replacement has a huge impact on many aspects of people's lives.
And it's a hell of a lot easier to rehab than a knee. It's completely different. I feel like most hips come in and a lot of them just walk in 2 weeks later.
Yeah.
Oh, pain's gone, I feel great. Just about jumping out of their skin.
Yeah, right. Yeah, we get a lot of happy patients. And very commonly they say, because the smart person will really think about it and make sure, put it off for as long as they can and really think carefully about the decision, and often they'll come back and say, gee, I wish I'd done this 2 years earlier. 2 years earlier, that's often the kind of response we get.
Absolutely. And for the listeners out there that are based in Sydney, or I assume do telehealth as well?
Yeah.
Yep. Where can they find you?
Well, my name's Bill Walter, and if you just Google my name, you'll find a website that's got all the information. But I work at Royal North Shore Hospital in North Sydney and the Mater Hospital in North Sydney. Both of those places I do surgery and see patients at North Shore and up on the northern beaches of Sydney. But we can do telehealth for anywhere in the country or in the world.
Some people have flown and have been flying to Sydney for the operation.
Yeah, we get patients from all around New
Especially
South Wales,
from regional areas and rural areas.
all around the country. Patients from New York,
Oh, right.
Europe sometimes. Yeah.
Why would they fly that way? Obviously, you're a good surgeon. That helps.
Well, you can't get this resurfacing in the US.
Right. At all. Surely there's a surgeon in the US doing.
Well, there are surgeons doing resurfacing, but they're still using the metal, and the ceramic on ceramic hasn't been approved there yet.
That seems crazy, especially after how you've just broken it down in terms of the differences. Why is that the case?
Well, it's not invented in America, so.
So they're waiting on another material that they'll invent in America that then they'll use.
So there are some resurfacings being done. There are some very good resurfacing surgeons in the US, and they are using. There's some other options. There are alternative bearings. There's a ceramic on polyethylene, which is very promising. So they're doing some of that in the US. The ceramic on ceramic, though, is manufactured in Europe and hasn't been approved yet in the US. The companies that manufacture them, and there's two different designs. The companies that manufacture them are both working on getting FDA clearance. And I should say that I'm actually involved in the design of the ceramic on ceramic. I don't know if I can put that up as a disclosure in the notes or something, but I'm involved as a designer of the ceramic on ceramic resurfacing. So.
We take shameless plugs on this podcast, Bill. That's absolutely fine.
No, I wasn't plugging myself. I'm just pointing out that I'm conflicted. Yeah.
I hear you.
Yeah.
Well, it's been amazing. We'll have to do a 2.0. I think you're built for podcasting. For the listeners out there, this is Bill's first ever podcast, and he's just taken to it like a duck to water. So thank you so much for coming on.
All right.
It's been an absolute pleasure, and we'll do it again soon. And as usual, stay strong.